Hello everyone. Today we will be going through some arthritic conditions about all those which are already listed on the slide. I will provide you with the timestamps so that it will be easier for you to navigate whichever one you are interested in. To the most common disease, that is the osteoarthritis. So here I need to stress that even though it is called itis, osteoarthritis, it is not an inflammatory disease. We all know that anything which starts with itis is an inflammatory disease, right? But here this is a non-inflammatory joint. So if it is non-inflammatory joint disease, then what is this? Why does this, what causes this? This is because of repetitive joint loading. There happens a degeneration in the joints. So this is basically a degenerative joint disease. So since it is non-inflammatory, there will not be elevated white blood cells and the ESR will also be normal. So why does the degeneration happen? The degeneration happen because of obesity, tall stature and excessive joint loading, like lifting heavy weights. So mostly the joint will be able to withstand all this until it for a particular age. So osteoarthritis, and even if the degeneration has started, it will produce all its symptoms only after around 40 to 50 years. So what are the classical findings here? Here if you see, because of the degeneration, there is asymmetric joint space narrowing. The joint space will be narrowed, but it will not be symmetric. Why should it be symmetric? Logically speaking, there will be degeneration. So depending on the anatomy of the joint and depending on the weight load, depending on our posture, depending on the way we stand, way we walk, there will be degeneration happening in the joints. So it will naturally be asymmetric. There need not be a symmetric pattern. And at areas of cartilage erosion sites, there is something known as hibernation. Hibernation is nothing but there is an ivory like appearance of the bone in osteoarthritis where there is cartilage erosion. So what is the primary treatment in osteoarthritis? It is weight reduction, weight loss, so that we need not load the already degenerated joint, and for that weight loss is the primary treatment. Along with it, we can take acetaminophen. Since it is not an inflammatory disease, so we need not treat it with non-steroidal anti-inflammatory, that is NSAIDs. Anti-inflammatory need not be given as a first step. Acetaminophen can be given as the initial therapy. But if acetaminophen is not effective, then we can go for NSAIDs. The third line is intra-articular steroids. You might be wondering, if there is no inflammation, then how would steroids help? You're right, but still steroids do help, especially in those who have failed with acetaminophen and NSAIDs. Fourth line is advanced therapies for surgical intervention like knee replacement. Let's see about osteoarthritis and rheumatoid arthritis. Here in rheumatoid arthritis, we should know that it is due to inflammation. I will come to it in detail in the next slide. Before that, let's see about the differences. Osteoarthritis is the one which will be affecting the distal interphalangeal joints. So when the distal interphalangeal joints are affected, it is known as the Heberden nodes. The proximal interphalangeal joints are also affected, and that is known as the Bouchard's nodes. Then asymmetric distribution, as we had already discussed, and there will be bonely enlargement also, and the inflammation will be very minimal. In rheumatoid arthritis, the only key differentiating feature is that the rheumatoid arthritis will not affect the distal interphalangeal joints, DIPs. So whenever you see an X-ray where the DIP is affected, then it is clearly indicating osteoarthritis. Rheumatoid arthritis will primarily affect the metacarpophalangeal as well as the proximal interphalangeal joints. And rheumatoid arthritis is something which is an inflammatory disease. So the body will be producing inflammation against the joints. So therefore, the inflammation will be even all throughout the body, right? So the joints will be also be affected symmetrically. Symmetric pattern is characteristic. Along with involving the MCP as well as PAP, it will also result in ulnar deviation. It will also result in a botanier deformity. Let's see in detail some more about rheumatoid arthritis. It has an autoimmune pathogenesis. Like it will target the synovium, thereby causing chronic inflammation. So since it has targeted the synovium, what happens is that there will be formation of pannus. What is pannus? This pannus is nothing but it is formation of new bones. The body will mistakenly attack its own synovium, that is the lining of the joint, and leading to formation of the pannus. The pannus is nothing but it is a new bone which is formed within the joints in rheumatoid arthritis. This new bone will now erode the already underlying normal bone as well as cartilage. That is, the pannus will erode the normal bone as well as the cartilage, leading to joint deformity, joint stiffness as well as pain. So this is the autoimmune pathogenesis, how it affects and how the pannus is formed, how it causes joint destruction. Along with the joints, it will also result in multiple organs problem too. So before that, let's see how do you assess rheumatoid arthritis. Rheumatoid arthritis, I told you, it is symmetric, it is polyarthritis, and it can occur in a females aged 20 to 40. Since it is autoimmune, it is often associated with a family history of autoimmune diseases. Say for example, they might say like the sister had a type 1 diabetes, or they themselves is also suffering from SLE, or anything, something similar to it, because they believe that the autoimmune diseases go together. The second one is that how do you diagnose? There are two ways to diagnose and confirm rheumatoid arthritis. First, or one way, is arthrocentesis. That is, you need to do a joint aspirate, and since this is an inflammatory disease, it shows elevated WBC levels, and there is also an elevated ESR. This is a one way. The other way is antibody testing, where you can check for rheumatoid factor as well as for anti-CCP. Here you should know that anti-CCP is more specific to rheumatoid arthritis than rheumatoid factor. So what is rheumatoid factor? Rheumatoid factor is an IgM antibody against the FC fragment of the IgG. So this also you should know, this will be tested in many exams. So when you see a radiograph, there is joint space narrowing and there is erosion, obviously, because here also there is erosion that is happening. In addition to it, there will be symmetric. So if you ask me, what will they ask you? Whether to do arthrocentesis or antibody testing? It depends patient wise to patient when you see the patients clinically. But in exams, they won't force you to choose between arthrocentesis and antibodies. Either one will be given, and you can choose either of it. In rheumatoid arthritis treatment, we have to focus on two important things. One, the patient will be having pain, so the symptom has to be controlled. Then second thing is the disease should not be allowed to progress. So for the symptom control, since it is an inflammatory disease, we use anti-inflammatory such as NSAIDs, and followed by steroids for symptomatic relief. To modify the disease, we use methotrexate. Methotrexate is the first line disease modifying agent. So it is to cause a slow progression, we use methotrexate. If the methotrexate, the second line is anti-TNF alpha agents such as infliximab, adalimumab, and etanercept. All this can also be used. So rheumatoid arthritis is something which can also involve other organs. Say for example, rheumatoid arthritis can cause pulmonary fibrosis, thereby restrict to lung disease. At the same time, the methotrexate will also cause pulmonary fibrosis. So one should know that both rheumatoid arthritis per se and the treatment methotrexate can cause pulmonary fibrosis. So restrict to lung disease in rheumatoid arthritis is often a mix of the disease, that is a mix of rheumatoid lung and methotrexate induced pulmonary fibrosis. Fine. There is one question where you will be given like a patient has sore wrists and sore knee. And that means they are pointing towards rheumatoid arthritis. And in addition to it, they also tell that the patient has diffuse pruritus, high serum cholesterol, high direct bilirubin, and high ALP. So question will ask, what is the treatment of jaundice? Here the patient has rheumatoid arthritis and high serum cholesterol, direct bilirubin, ALP, and diffuse pruritus indicates that the patient is also having primary biliary cirrhosis, because the autoimmune diseases go together. So the treatment of jaundice is ursodeoxycholic acid. This is because ursodeoxycholic acid, that is ursodiol, will cause decreased secretion of cholesterol into the bile. Therefore, this is the treatment. What are the extra-articular manifestations of rheumatoid arthritis? Let's see what are all the extra-articular manifestations that rheumatoid arthritis causes. Rheumatoid arthritis causes pulmonary fibrosis and restrictive lung disease. It can be also due to methotrexate induced. Cardiac, it can result in serous pericarditis. So therefore they will be presenting with friction rub. SLE will also result in pericarditis. So both rheumatoid and SLE will cause pericarditis. Then any disease of chronic disease like rheumatoid arthritis will result in anemia of chronic disease, hematology will be there. Then deformity, we know that it will be resulting in PI when swan neck. Swan neck is exactly like a swan, where there will be proximal interphalangeal joint extension and flexion of the DIP. Botanier is flexion of PIP and extension of DIP. Okay. So there is another two more syndromes which are associated with rheumatoid arthritis. When this is associated with pneumoconiosis, that is rheumatoid arthritis with pneumoconiosis is Kaplan's. Rheumatoid arthritis with neutropenia with splenomegaly is Filtes. They will be giving directly questions like a middle-aged man with a sore knees with a high ESR pointing towards RA with low neutrophils and spleen palpable. Question asks, what is the diagnosis? Straight up this is. It is Felty syndrome. The next chapter is about juvenile idiopathic arthritis. This is also known as juvenile rheumatoid arthritis. So as the name says, like juvenile rheumatoid arthritis, it is exactly a rheumatoid arthritis which was seen in juvenile. That is a regular rheumatoid arthritis in a kid, where they say that there is multiple episodes of joint pain. In addition to joint pain, in about 50% of the cases, there is classic salmon pink maculopapular rash in approximately 50% of rheumatoid arthritis patients. In addition to that, they will also be presenting with fever. So, where it is because of due to cytokine release, they will be having high grade spiking fever. So, this is another presentation. So, either they will be presenting with adult, just like adult rheumatoid arthritis in a kid, or they will be having high grade fever with rash with joint pains. So, the fever is because of cytokine release. Sometimes when there is fever, you can, it might resemble as septic arthritis. But in septic arthritis, there is usually only one joint is affected, and the one joint will be red erythema and along with fever. Here in juvenile rheumatoid arthritis, it is polyarthritis along with fever, and the fever is because of cytokine release. So psoriasis. Psoriasis is a condition which will affect the skin as well as the bones. So in the bones, it will be resulting in pencil and cup deformity. That is a characteristic X-ray appearance which is seen in psoriasis. So what does it mean by pencil and cup? It describes the destruction and abnormal shaping of the bones at the end of the joints. Say for example, here there will be an abnormal destruction and a shaping. So such that because of shaping, it becomes, and a destruction, it becomes a pencil. The distal phalange becomes a pencil, and the phalange that is proximal to it, because of the destruction and shaping, it appears like a cup. So if you see the typical X-ray, this is how it will be present in psoriasis. Because the distal phalanx is tapered, giving it a pencil-like appearance, and the articular surface of the opposing bone, that is usually the adjacent part, becomes cupped or concave, resembling the shape of the cup. So this is known as the penicillin cup appearance. Mostly patients with psoriasis, they will be having almost 85%, they will be having only skin findings first. But 15% of the patients with the psoriasis will get arthritis before any skin findings. This is the second point you should know. Thirdly, one should know that the plaque which is seen in psoriasis are described as silvery and scaly over the extensor surfaces mostly. They will be showing up on the back, they will be showing it on the face, that is in the forehead, and also sometimes in the lip also it can be seen. So if those scaly lesions, if that is removed, it will result in bleeding. That is known as the Auspitz sign. Another characteristic which is seen in psoriasis is munro micro abscesses. That is pathognomic for psoriasis. What is that? That is nothing but there will be collection of neutrophils in stratum corneum of the epidermis. So that is known as munro micro abscess. So this is an overall about psoriasis. So psoriasis, it is actually a part of HLA-B27 constellation. What is HLA-B27 constellation pair? That is, P stands for psoriasis, A stands for ankylosing spondylitis, I stands for IBD, and R stands for rheumatoid arthritis or reactive arthritis. And what is the treatment in psoriasis? Psoriasis is generally treated with topical therapies at the first line. So it has to first start with vitamin D derivative, that is the calcipotriene. After vitamin D derivative, if that doesn't cure the patient, then we can give them steroids like triamcinolone or corticosteroids. What one should know is steroids will result in a skin thinning. So therefore, it is started with vitamin D like calcipotriene. Second line, when there is the patient is also given a systemic therapy for plaque psoriasis or for psoriatic arthritis. So oral methotrexate is the first line systemic therapy which is preferred. Biological therapies like anti-TNF alpha agents or interleukin 17/23 inhibitors are those which are reserved only for refractory cases. So the most common is the first and the second one. USMLE exams have like to combine scenarios. Say for example, psoriasis is the one which is associated with the HLA-B7 constellation, isn't it? And it is likely associated with I stands for inflammatory bowel disease. So the question will be in such a way that 22-year-old male with a silvery plaque on the elbow and the forehead with bloody stools, which is so what does it mean? It means that they are suffering from psoriasis as well as inflammatory bowel disease due to HLA-B27 association. Now we are again coming on to ankylosing spondylitis and sacroiliitis. Ankylosing spondylitis is the most severe form, and sacroiliitis is less severe than ankylosing spondylitis. Sacroiliitis is a broad term that refers to just arthritis of the lower back. So, when there is a lower back pain in patients with inflammatory bowel disease, psoriasis, or reactive arthritis, then it all points towards sacroiliitis because of the HLA-B27 association. So, how does the patient generally be? The patient will be mostly around the 20s to 40s, and they will be having a morning back pain which will improve with activity. When an X-ray is taken, it will be presenting with a bamboo spine just like this due to vertebral fusion. Along with the bamboo spine, they will also be having anterior uveitis. So this can be sometimes tested in the exams, like they will be giving you a scenario of ankylosing spondylitis and then ask what should the patient also be tested for. They should also be tested for anterior uveitis with slit lamp examination. This can result in may develop restrictive lung disease, which is not really common. But what is common is that it can result in anemia of chronic disease. Sometimes 20% of the patients with ankylosing spondylitis can present with aortic regurgitation due to inflammation of the aorta. So this happens only in 20% of the patients, but still sometimes this is tested in the exams. Treat the treatment is the same as rheumatoid arthritis. SLE is an important topic which sometimes is confusing, but there are only few important points which you should know for sure. First one is that arthritis. Arthritis is the most common presenting feature in lupus patients. This is the first one. So this is how most of the SLE patients will present. Second one, which is really confusing, is about the antibodies. It is important to know that anti-DS-DNA will correlate with the flare. But whereas anti-Smith is the one which is most specific for SLE. What about the renal involvement? Lupus nephritis will present as diffuse proliferative glomerulonephritis. It will also, in cardiovascular, it will present as pericarditis. In neurology, it will present with lupus cerebritis or transverse myelitis, just like Brown-Sequard syndrome. So, an overview about the antibodies. Here it is the anti-DS-DNA and anti-Smith antibodies. So this anti-DS-DNA will correlate with disease activity as well as with renal involvement. Disease activity in the sense if there is any flare-up, there will be an increase of anti-DS-DNA, and with renal involvement also anti-DS-DNA will be increased. The second one is anti-Smith. S stands for S in that sense. With anti-Smith antibody is the one which is most specific for SLE diagnosis. Third one is the antihistone antibodies, which is presented drug-induced to lupus. So, in cases of procainamide, where a patient is taking procainamide or hydralazine, they can present with SLE, but it is because of these drugs. So, in that case, to differentiate it from the actual disease and whether it has been due to triggered by the drug, we check this antihistone antibodies. The fourth one is the antiphospholipid. It is mostly elevated in APLA, antiphospholipid antibody syndrome. But since those with SLE can also have APLA and the vice versa, antiphospholipid antibodies are also sometimes seen to be high in SLE with APLA. Here it causes thrombosis and recurrent miscarriages. Lupus anticoagulant is also the one which is increased in APLA, and it paradoxically it will cause thrombosis, but APTT is also elevated. If APTT is elevated, it means there is an increased bleeding risk, but in vitro, in vivo, inside the body, it will result in thrombosis, yet the APTT will be elevated. Another important concept about SLE is that its association with the complement. Any complement deficiency is associated with SLE, or during SLE, there is a deficiency of the complement. That means there is a drop of the complement levels. So let me explain this to you. When there is a C1q deficiency inherently, then that will increase the risk of SLE. But if there is an acute flare of SLE, then C3 levels will drop during the acute flares. So when they inherent a C1q deficiency, then they are at an increased risk of SLE. And even when they don't inherit any complement deficiency, but just like that, when they simply have SLE, then C3 levels will drop during the acute flare-up. This is the concept. Then in SLE, there is also peripheral destruction because of these antibodies. So therefore, they can even present with a thrombosis. So in gout, what happens is that there is monosodium urate crystal deposition in the joints, leading to arthritis of the knee, arthritis of the hands, or arthritis of the big toe. In whatever joint the monosodium crystal is deposited, there will be arthritis. So but what is the most common arthritis? It is when the monosodium urate crystals are deposited in the big toe or the great toe, that is called as the podagra, and that is the most common presentation of the gout. This happens in middle-aged men with a male predominance who are alcoholic, who take meat, and there is an excess of urine consumption too. How will the crystals be? The crystals, just as you look here, they will be needle shaped, they can be yellow, they will be negatively birefringent under the polarized light. Sometimes under the microscope, so because of the appearance, because of the needles being arranged in this way, it is not a very characteristic, but sometimes they can also appear like a rosette. The crystals which are caused by this gout, that is monosodium urate crystals, cannot be seen on X-ray because they are radiolucent. The treatment of gout is indomethacin. So what happens in gout? The primary issue in acute gout flare is inflammation, which is caused by immune system's response to the urate crystals. This inflammation will lead to intense pain and swelling characteristic of the gout. So therefore, to stop the inflammation, NSAIDs are the first line treatment. What kind of inflammation happens? The inflammation is done by the neutrophils. So colchicine works by inhibiting the activity of the neutrophils, which is an inflammatory response to the monosodium urate crystals. Neutrophils are attracted to the site of crystal deposition and they will release the inflammatory mediators that cause pain and swelling. So therefore, if that neutrophils are stopped, if that inflammation is inhibited, then it is that serves as a first line treatment for gout, like indomethacin as well as colchicine. On the other hand, if you see what is the treatment for chronic gout, that is the aim to treat the chronic gout is to prevent recurrences. So the treatment is xanthine oxidase inhibitors such as allopurinol or febuxostat are given to prevent recurrence. What about the probenecid? Probenecid is a drug which will inhibit the organic anion transporter in the kidney, which will inhibit both the reabsorption of the uric acid as well as secretion of the beta lactams. Mostly probenecid is given along with beta lactams such as penicillin so as to prevent the secretion of penicillin in the urine and thereby to retain the penicillin in the blood for its effects. So probenecid is basically, it is not really a treatment for a gout, but still it works in a way that it can be used as a treatment for gout. But probenecid should not be given to patients with a history of urolithiasis because the drug is uricose-uric, causing increased excretion of uric acid within the renal tubules. Because the drug per se will inhibit the absorption of uric acid, therefore it is uricose-uric and it will cause urolithiasis. So therefore in that case it should not be given. The other two conditions, that is the post-traumatic arthritis or toxic and toxic synovitis. What about them? Post-traumatic arthritis is nothing but there is arthritis following a trauma. So it can present either immediately or shortly after a trauma or years after the trauma. There can be joint pain. That is post-traumatic arthritis. And so to diagnose post-traumatic arthritis, a trauma or a joint injury is essential. The radiograph may show prior fracture or joint deformity. The treatment focuses on underlying structural damage. Whatever the damage that has been caused by the trauma has to be repaired or attention has to be given to that. Then the arthritis will get better. In toxic synovitis, here there is transient hip inflammation and this happens mostly in pain. But what is toxic? It is following a viral infection. It is a diagnosis of exclusion when septic arthritis is unlikely. What happens in septic arthritis? There will be no predisposing factor. But in toxic synovitis, it is predisposed by a viral infection. And septic arthritis is very severe, but toxic synovitis is less severe with better weight bearing ability. For toxic synovitis, the treatment is NSAIDs only, ibuprofen. How will the question with post-traumatic arthritis present? It will first sound as if there is some other condition. Say for example, they will be giving you a MLA question like 2 years of knee pain, which is first worsened with basketball. So there is a 2 year of knee pain and which is worsened with the basketball. Then what will anyone think? They might be wondering that what if it is a patellar tendonitis? But then progresses to more constant pain. Everything sounds like patellar tendonitis, isn't it? Then they will be going on to say that the patient had a fracture to proximal tibia 30 years ago and has the varus deformity of the knee. So what is the underlying problem? Underlying problem is fracture 30 years ago and having the varus deformity is the underlying problem. So therefore the diagnosis is traumatic arthritis and not patellar tendonitis as it first sounded like. Okay. What about reactive arthritis? Reactive arthritis is the one which it is a classic triad. So it is mostly the one which is occurring after chlamydial infection. Chlamydial infection is the most common and the gonococci will not cause reactive arthritis. This is the one which confuses many. So it is most commonly occurring after chlamydia and it does not occur after the gonococci. But other than chlamydia, there are some more organisms which can also cause reactive arthritis such as rubella, hepatitis B, hepatitis C as well as Yersinia. So all these can also cause reactive arthritis. What happens in reactive arthritis? In reactive arthritis, urethritis, arthritis and eye inflammation can happen. Reactive arthritis is also a part of PAR which stands for P for psoriasis, Ankylosing spondylitis, inflammatory bowel disease. R stands for rheumatoid arthritis as well as for reactive arthritis. We already talked about septic arthritis in little. Let's see it in more detail. In septic arthritis, the most common cause of septic arthritis overall is Staph aureus. It is a key pathogen in prosthetic joints as well as in rheumatoid patients. But in young sexually active adults, gonococci is the most common cause of septic arthritis. It will not only present with arthritis, it will also present with tenosynovitis as well as the skin lesions. In septic arthritis, the first important step is arthrocentesis. So first surgical drainage to know that it is only septic arthritis plus antibiotics is an essential management. The biggest risk factor for septic arthritis is that abnormal architecture. So it can present as four main types. First one is that it can happen in prosthetic joints or it can happen in patients with micro trauma such as recent car accident or in high intensity exercise, or it can happen in a juvenile rheumatoid arthritis or else an osteoarthritis. Finally, it can be seen in sickle cell disease too. So this can be presenting with a question like a child who is having a painful left hip for 2 days. Fever of 101 degree Fahrenheit. Septic arthritis can be associated with the fever, isn't it? Leukocytes are elevated and they cannot bear weight on the hip. Question says nothing about warmth or tenderness of the hip. Now question asks what is the next best step. Here you should know that this is not toxic synovitis because there is no predisposing viral infection. Septic arthritis per se has resulted in fever and also elevated leukocytes. If it is toxic synovitis, it will not be as severe as septic arthritis and they will be able to bear weight on the hip too. Here they very clearly say that they cannot bear weight in the hip. So when the question asks what is the next best step, you have to come to a conclusion that it is septic arthritis and the next best step is arthrocentesis. Sometimes they might even give you a predisposing factor like juvenile rheumatoid arthritis. Say a child has intermittent knee pain with a salmon pink body rash plus presents today with red hot painful knee with limited mobility. So salmon pink body rash, intermittent knee pain and a painful knee with limited mobility all points towards juvenile rheumatoid arthritis. Now here the juvenile rheumatoid arthritis need not be red and hot. So there is a predisposing, the joint architecture is abnormal and along with it there is this red hot painful knee which is pointing towards a septic arthritis. So juvenile rheumatoid arthritis is a risk factor for septic arthritis. middle-aged man, when he, another question like this, a middle-aged man when he goes for a painful, when he went for hiking, had a painful red knee with a fever of 102 °F. He went for hiking for 12 hours 2 days ago. So what is the most likely organism which is resulted in? So it is septic arthritis, and the most common organism is Staph aureus. So that's what. Just a small overview about the crystal-induced arthropathies. Here we saw about gout, which is a monosodium urate crystal deposition, and it is negative birefringence. It is needle-shaped and it is a first metatarsal phalange joint is the first one, which is is the one which is commonly affected. Pseudo gout, the crystal type is calcium pyrophosphate, and it will be positively birefringent. Pseudo gout is the one which will be rhomboid in shape. It happens in the knee and the wrist. There is another entity known as Milwaukee shoulder. Here it is a cold shoulder, that is, it is non-inflammatory. So crystal type is basic calcium phosphate. It doesn't show any birefringence, but it will appear as small spirules. So just basic calcium and phosphate are the one which is present, and it is seen in shoulders. With this, we have come to almost the end of the slide. I just want to give you an overview of the organisms. So Salmonella is gram-negative rod. What is the importance of Salmonella? Salmonella will result in osteomyelitis in sickle cell disease. But septic arthritis in sickle cell is by Staph aureus. Staph aureus is gram-positive cocci. So this knowledge is also important because they might give you different variable scenarios. So this knowledge might come handy. Gonococci is gram-positive diplococci. Chlamydia is the one which is responsible for reactive arthritis. So generally, the general cause of septic arthritis is Staph aureus. But septic arthritis in sickle cell is also Staph aureus. Osteomyelitis in sickle cell is only Salmonella. In a sexually active young man or women with a septic arthritis, it is gonococci. What causes psoriasis abscess? Obviously, it is TB, but Staph aureus can also result. Thank you, everyone. I hope this elaborate presentation is of use to you. This is mostly I have concentrated on USMLE questions, and I have just this has an overview of only those USMLE chapter. But if you like my videos and if you like the way I teach you, and if you want to get mentored by me, you can go ahead. I have, that is the announcement. You can go ahead, send a message in the comments, and I teach for medical graduates as well as USMLE aspirants. Looking forward to see you succeed. Have a good day.